Hello, everybody. On behalf of York Hospital, welcome to today's Zoom webinar. Before we get started, we have a few quick housekeeping notes to review. Today, York Hospital presenters will discuss COVID-19 vaccination questions for approximately 20 to 25 minutes, followed by a question and answer session. Unlike traditional Zoom, when you see everybody's faces during the webinar, you will only see the presenter's face and slides. As participants, your audio has been muted, so if you do have a question, you can type it into the Q&A button located at the bottom in the center of your screen. Please do not use the chat or raise hand buttons, as those will not be monitored during this call. If you ask a question through the Q&A feature and it is not answered during this meeting, you can email us at info@yorkhospital.com and we will get you an answer after the call concludes. This webinar is also being recorded and will be available on the York Hospital YouTube channel next week. Today, we will hear from a number of York Hospital medical experts who will address your questions about COVID-19 vaccines and highlight the importance of continuing to stay safe and informed by watching your local positivity rates, knowing your personal risk for severe COVID-19 infection and the risk of those around you, understanding how vaccines work and help protect public health. Dr. Evangeline Thibodeau, York Hospital Infectious Diseases Physician, Chair of Infection Control Committee and Director of Immunization and Travel Services, will lead today's discussion and address common questions and concerns about vaccines. She will then open the conversation to include other York Hospital panelists, including Dr. Todd Adams, Internal Medicine Physician and Lead Physician of York Hospital Provider Organization, Dr. Jennifer Cutts, our Chief Medical Officer, Dr. Michael Vinograd, Chief of Pediatrics, and Dr. Gretchen Volpe, Infectious Diseases, Immunization, and Travel Services. So now, once again, thank you very much for tuning in today and spending this time with York Hospital. We hope you find the information helpful, and we're pleased to go ahead and get started by turning the program over to Dr. Evangeline Thibodeau.
Thanks, everybody, for coming, and thank you, Hillary, for that introduction. I'm really excited to be here. I want this to be mostly Q&A because we're here for you. We're here to answer your questions. I'm going to go through the agenda here. I'm going to talk a little bit about COVID-19, but most of you all know enough about that now. We're going to talk about strategies to fight a pandemic, which includes vaccination, but is not the entire picture. I will talk about herd immunity, the different vaccines offered here in the United States, why we vaccinate, and then answer the common questions that we get, as it's probably a lot of questions that you have. And then we'll open it up to the audience and the panelists to hear a lot about your questions and really try to walk you through your decisions. So I first just want to say, from the infectious disease standpoint, I've never seen something like COVID-19 before. You have a disease that has 20 to 30% of people who are asymptomatic, and then 10 to 15% of people who have severe pneumonia and, a pretty high mortality rate, probably around 2%. And then we have everything in between. We have multi-organ involvement. So we have everything from the respiratory infection to GI symptoms, to cardiac symptoms, to neurological symptoms, to different effects on if you're, a child or an elderly person. It's really not from our patient standpoint, but from the infectious disease standpoint, it's actually a pretty fascinating virus. And we've learned so much over the past year. And I bet if I give this talk in a year from now, I'd have completely different slides, because I'm sure we're going to learn much more. So that's what I wanted to say about COVID-19 in general as the disease process. First of all, I always tell people, know your local rates. And this was just updated about 10 minutes before the presentation. I checked the Maine CDC. I go to this site almost every day. You can look at your local rates, look at your county rates, look at what's going on in Maine. And the two numbers I look at is the positivity rate. In York County, we actually are at 3.8%, which is coming down. As a state, we're 2.5%. So these numbers kind of just gauges how well we're doing. And I look at the trend, and if we're going up, if we're going down. I look at the positivity rate as well as the case rate. We make some decisions in the hospital system based on some of these numbers, but it kind of gives you a sense of how much COVID is going on in your community. I also want you to understand your risk and the people you interact with and their risk. So are you or people around you, people in your household, people you work with, are they at high risk for severe disease? We know that by now. We know people older than the age of 65 or with certain medical conditions. immune suppressed patients, we know that they're at high risk of disease. So are you or anyone around you at high risk of disease? Do you work an essential job where you may be in touch with people that you don't know their risk status? Really, how many people are you interacting with outside of your home? Because that really gets to the concept of herd immunity, which I'm going to be talking about. I like this visual because it goes to show that vaccination is not the only tool we have to fight this pandemic. I actually first saw this last year before vaccines were introduced, and we added another slice of the cheese more recently with the vaccines. And really, I think the vaccines should have a huge slice of cheese. But everything here, this just goes to show that there are multiple layers of protection, and none of them are perfect. Even vaccines, they're not perfect. So we have to continue to do all the other strategies we've had in place over the last 14, 15 months, the distancing, the masking, looking at our ventilation, working with our communities, working with our government, and quarantine, all these different strategies we have, and some of them are personal, and then some of them again are shared strategies. So vaccine was just added, and it's an excellent tool, but I just don't want us to forget about everything else. So what is herd immunity? The other term you can call it is community immunity, because it's really looking at the protection of your community, your bubble, however big you want your bubble to be. The term really means it's when you vaccinate yourself, you're reducing the number of opportunities for the virus to go on and infect other people, to replicate and to go on and infect other people. I don't want to get too technical. You've probably heard of the term R naught. I think it's helpful to understand what this means because it gets to herd immunity. So R naught, this little figure over here, is the number of people one infected individual with disease goes on to infect. So if I had COVID, how many other people would I give it to? And the reason this is important is that herd immunity is actually a calculation. So it actually is 1 minus 1 over R naught. So that's why it's really hard to get at herd immunity. That number changes because R naught changes. So R naught changes on an individual basis, like children, they're not as good transmitters of the virus than in the middle-aged population. And then R naught also changes with some of our variants. Some variants are transmit more easily than other variants. So that's why herd immunity is really an estimate, and we don't have an actual number. It's different for every disease state. And it's also estimated, it's different for COVID because we're getting more variants and we're learning more about it. So that's kind of where it comes from. It really, the concept of herd immunity, it protects people who cannot get vaccinated or really who suboptimally respond. So who are these people? Children. Currently, the vaccine's not approved for children under the age of 16, although that may be changing soon. People with contraindications to vaccines, severe allergies. And then this last one is really important. Immunocompromised individuals, transplant patients, patients who are on chemotherapy, they really may not respond optimally. They don't have as robust of an immune system to mount a proper protection. So we really need to shield them from the virus so that they don't go on to have a severe disease, because that data is actually coming out now that we do think that immunocompromised individuals probably don't respond as well to vaccine as a normal host would. Herd immunity really relies on the majority of the population to get vaccinated. And like I said, this estimate, it ranges. So 70%, some people say up to 90%, and this is going to change based on these variants. So we really don't know what that magic number is going to be, but it's somewhere probably in this range, 70 to 90%, to make an impactful, to make some kind of impact on transmission. Like I said, children under the age of 16 are not currently eligible for vaccination because there's no emergency use authorization for this age group, and they make up about 20% of the population. So there you go, 20% aren't getting vaccinated right now. So we really depend on everyone else to get vaccinated. And remember, this is a pandemic. So yes, we can talk about our local bubble. We can talk about our community in York. We can talk about Maine, New England, but really it's a pandemic. And so we need to vaccinate as much of the world, really, if we want to get back to some kind of normalcy. We're actually pretty lucky here in the United States. We've had pretty good access to vaccine, but that's not the case in some of other parts of the world. And really the goal here, I think people think that we're going to be getting rid of COVID. We know now that we're going to live with COVID. It's not going away. It's going to be part of our healthcare system. As an infectious disease physician, I think I'll be seeing COVID for the rest of my career. The goal is not to eliminate it, but to just get it down to like a dull roar. So basically, it just becomes a seasonal respiratory virus, almost like influenza, so that it just gets to a point where maybe we have little spikes here and there in certain areas, or maybe in certain seasonality, but that it doesn't impact our healthcare system and it doesn't impact our economy like it's in just our public health in general, like it has over the past 14, 15 months. The only infectious disease completely eradicated is smallpox. So it's very difficult to completely eradicate. I'm not going to go into all the virology of it, but it's quite difficult to completely eradicate a novel infection. The last piece is just to say that vaccination, not only is it great for all these other herd immunity, it also curbs the development of new variants and new strains, which again gets back to that R naught, that we don't want new variants to change that are more transmissible and make that threshold higher and higher for how to get to herd immunity. This slide here just goes to show that we've done this before. There have been novel infections before and new vaccines introduced, and look at the numbers of infection that have just completely tailed off. So polio has been eradicated in the United States, but we still give the vaccine actually because it is it's endemic in other parts of the world. So again, it's a pandemic. We all have to kind of think globally about it. And we have done this before. We've given vaccines and we have done really well in terms of tampering down numbers of infections. All right, this is my most technical slide. I will try to not bombard you with boring data, but this is about the vaccines we have right now in the United States. We have the 2 mRNA vaccines, Pfizer and Moderna. They are 2 doses, 3 to 4 weeks apart. Most people know this by now. The efficacy, it's confusing. It confuses me when you say, oh, it's 95% effective, it's 99% effective. So the data that I looked at, it's really 90% effective at preventing COVID, and this is over time. I'm going to give you some kind of raw data to show you, like in terms of breakthrough infections, how many infections we've actually seen in fully vaccinated people, but that's pretty good. 90% is a really good vaccine. We have other vaccines that we give to people in the travel clinic that are only 50 to 60%, but they'll take it because, you know, it's chances are you won't get it. But 90%, anything over 90% is really an excellent vaccine. Immunity for both of these vaccines has been shown to last at least 6 months, possibly longer. Side effects are fairly common, as you've probably heard, injection site pain, systemic symptoms, anything from headache, muscle aches, but it's very short-lived, 36 hours at most, 48, and it's typically after that second dose. Has been a little bit more propensity to affect women than men, possibly a hormonal component to it, but again, very short-lived, and having the side effects does not mean, if you don't have the side effects, does not mean that you did not mount a good response. So probably still did, it's just everyone reacts a little bit differently. Anaphylaxis, so the mRNA vaccines have had some episodes of anaphylaxis. This is the number, 1 in 11 million. And at our vaccination site, we do observe people with this history for a little bit longer than we do a typical patient. So again, the risk is low, but we have procedures in place to observe and as well as to respond if there were if someone did have a severe allergic reaction. So the J&J vaccine is an adenovirus vaccine. It's the one and done vaccine. It's very convenient because you just get 1 dose and you reach your full protection earlier than you would of the 2-dose series. Efficacy is quoted about 67% against COVID. And now everyone says, okay, well, I want the mRNA vaccine. I don't want the Johnson & Johnson. It's a better vaccine. That's actually not true. These vaccine trials were set up very differently. And so the 67% is actually still an excellent vaccine. And I'm going to get to this in a minute, but both vaccines or both categories of vaccine are nearly 100% effective at preventing hospitalization and death is what really our goal here. Side effects, about 50%. I had more data on how many people get injection site pain and systemic symptoms. Probably a little bit fewer side effects with the J&J. So if you're a little more concerned about side effects or going through the 2-shot series, J&J may be a little bit more appropriate for you. I want to talk about the pause real quickly. So on April 20th, the FDA put a pause on giving out the J&J due to the observation of 6 cases of this cerebral venous sinus thrombosis. This is a rare blood clot. And I want to emphasize that the pause actually gave me more confidence that the FDA is really thoroughly investigating all these processes. And they really paused it for that reason, to say, hey, guys, what's going on here? Let's look into this, and to alert the healthcare community. So the pause was really so that healthcare providers could recognize the blood clot disorder, as well as patients, if they had received J&J, if they had any symptoms, that they could alert their healthcare provider. The healthcare provider also, they needed to recognize it, and also very importantly, the treatment was different than how we would treat typical blood clots. So the pause was on April 20th. They total about 15 cases. There might be a few more cases since this, mostly in women under the age of 49. So the overall risk is 2 per million, and a little bit higher in that age women category. So the risk of this blood clot from the J&J vaccine is actually lower than the risk of blood clots from COVID-19 illness. So the risk is quite low. So I just wanted to talk about that. It was resumed on April 23rd with this warning for women under the age of 49. Just a little bit about breakthrough infections. So this is an infection if you get a diagnosis of COVID 14 days after your second mRNA vaccine or after your J&J vaccine. If you look at the data, they published some data. This was in healthcare workers. Over 7 million healthcare workers were observed, and 5,800 were documented breakthrough infections. Look at that rate. It's pretty low. So this is where our vaccines are just so excellent. I have some data on Maine, 157 cases that were documented as of yesterday, with over 1.1 million people vaccinated. Again, very, very low numbers here. I'm just going to say this again, that both vaccines are nearly 100% effective at preventing hospitalization and death, and really that's our goal here. Sorry, back one moment on the breakthrough infections. The majority of these infections, mild cases. I'm not going to say it's going to never prevent hospitalization and death. There's not going to be an absolute zero risk scenario, but it's becoming exceedingly rare. All right, full immunity is achieved 2 weeks after the final dose. So that's what a breakthrough infection would be, is if it's 2 weeks after your final dose. This was one of our questions. I'm going to get to it a little bit later in the Q&A. Transmission in a fully vaccinated person. So can a fully vaccinated person give it to an unvaccinated person? This data is hard to follow, but the answer is likely no. Is it possible? Maybe, but exceedingly rare. Okay, so here are some common questions. The technology is new. I like to use the word not new, I like to use the word ingenuity. And I get it. I was probably one of the first people in this country outside of clinical trials to get the mRNA vaccine. I'm not going to tell you that it wasn't a little bit scary, knowing that you were going into that. But you know, I looked at the data, I looked at the EUA, we've been through this. I look at the risk benefit analysis of what we've been going through this past year with COVID, and I felt very comfortable getting it. So there's all types of vaccines. You hear this live vaccine, inactivated adjuvant RNA, DNA, adenovirus. What does this all mean? Basically, you need some kind of vehicle to deliver the vaccine and allow your body to mount an immune response. And this technology is evolving all the time. Like I said, it's ingenuity. And the mRNA vaccines, the mRNA, it's a code that basically allows your body to create this kind of fake protein that then your body goes on to generate antibodies, so that it has that, and that fake protein kind of looks like COVID, and your antibodies are generated so that if you were actually to be presented with COVID, then you had those antibodies already stored. mRNA does not get into our DNA. It just doesn't work that way. And the safety and efficacy data, like I said before, is actually very favorable. I actually feel that this technology is going to be changing medicine. We're going to have other vaccines in the future that are probably going to use this platform. It's possibly going to be easy to generate booster shots for variants. It's actually, I'm excited about this new technology. Adenovirus is also a new technology. It works a little bit differently. It uses an actual virus as a vehicle to generate that antibody response. And to be honest, both of these vaccines have been in development for decades. This isn't anything brand new. It's just the first time we've put it into practice. And it was just such an expedited process due to the pandemic. So what is this emergency use authorization? Again, it's an expedited review process, but really they don't sacrifice safety. They just put all their efforts in concentrated efforts. These are career scientists who dedicate all of their time and energy to look at the data and to decide if these vaccines are looking at the safety and efficacy. For emergency use authorization, you still have to look at least 2 months after for safety data. And typically, if you're going to see an adverse reaction to a vaccine, it's going to be within the first 2 months. I'm not going to say there's going to be no long-term effects from these vaccines, but that's very unusual based on what other vaccines have been introduced. And again, looking at that risk-benefit ratio of the risk of you getting a rare side effect down the line is probably exceedingly rare compared to your risk of getting COVID and side effects of COVID that we've seen and that we'll talk about a little bit later. And I just want to remember in terms of the efficacy that FDA last summer promised they would not approve something unless it had 50% efficacy. So again, having something that's 90%, I mean, I think we really scored here. So why do we vaccinate? I've talked about the personal risk. We don't want to get COVID on an individual basis. We do it for public health risk. We do it to protect our bubble, to reach herd immunity sooner, to decrease the risk of others who may not be able to get vaccinated or have suboptimal response, and just to kind of tamper down all that level of virus circulating. Variants, I talked about this as well. We decrease the risk of developing further variants. Right now, our vaccines are excellent. They all have pretty good protection against all the variants that have been detected out there. But, you know, what's going on in India right now, there could be a new circulating variant given the amount of virus that's circulating. There could be a new variant that turns up that maybe it doesn't affect, our vaccines aren't as effective, or maybe it affects children more. You know, who knows what could happen with some future variants. So the more vaccination we can do now, the less risk of future variants. The hospital impact, we're going to talk about this a little bit later. Remember, we talked about flattening the curve, spreading out infections over time. We also don't want to overwhelm our healthcare system, and we want to be able to do our jobs. So COVID has just reprioritized all of us in terms of focusing more on shifted our priorities so that other things on our docket just get less priority. So that takes away from all of our care and our jobs that we're trying to get done. I talked about this, that it's not just about the beds. And then the economic toll, lastly, you all can understand that as well. So these are some of the common concerns. I'm going to go through a few of them, and then I really want to open it up to the panel, and everyone can give their give more of their professional opinion and professional perspective on things, and then we'll open it up to questions. So this is one I hear a lot. Well, COVID is no different than the flu, but you can just look here to see the past from 2020 through 2021. This is the x-axis here is months. You can see that our deaths from COVID in blue is way higher than previous seasons of influenza. So it is very different from the flu. The mortality is quite different. Yes, they're both respiratory viruses, but they behave quite differently. Like I said, they have such a wide range of presentations, as well as this higher mortality rate. And certainly we had surges at our hospital over the winter that were nothing near compared to some of our influenza surges. Well, I'm not at high risk of disease. I don't need to get vaccinated. There has been data out there that 60% of people non-hospitalized have a higher risk of death at 6 months. So 60% of people diagnosed with COVID, compared to people not diagnosed with COVID, they have a higher risk of death. So it's really, we don't know some of the long-term effects of COVID and what that's going to do and how it's changed our immune system. Long COVID symptoms, we've seen a few patients now in our hospital or in our clinic, we're getting some referrals. We're sending them out to some of these long COVID symptoms. And it's not just, the shortness of breath, the headache, the fatigue. There's some psychiatric symptoms that this can persist 6 months after COVID, and, can be very disabling for patients. I already had COVID. Well, we don't know. The natural immunity is estimated to last about 90 days. So you really need the vaccine to make that immunity durable, to make it last longer. And same goes with the two, some people are foregoing their second COVID shot. We really need, for the mRNA vaccines, you really need both vaccines. Just like if you've had COVID in the past, you need to get vaccinated, because we know that can really cement in the immune response. And make your immune system more, just make it last more. So Maine has low rates. I can show you here that we have definitely had a few surges, and look at us right now. We're not too far off from where we were in December. We still are seeing high rates of disease, and look at what's going on in India right now. Or the figure to the right. So the figure to the left is Maine. The figure to the right is what's going on globally, and this is largely driven by India and some South American countries. Our rates now are the highest they've ever been. So we are certainly not done with this, and we could be the next India. I think nobody is immune from this. Look what happened it started out in Italy, and then New York City, Arizona, California, and you can keep going on. North Dakota, rural state. We never thought that we'd have huge surges in North Dakota. So, I don't think anyone is immune from this. Rural, urban, whatever you think. I think we all have to to use the term, we're all in this together. Pregnancy and fertility breastfeeding. So these women were not, have looked at data based on the vaccine reporting systems that there's been used, and there is no evidence of infertility, no evidence of higher rates of miscarriage. And pregnant women are actually at a higher risk of severe disease. So it actually behooves them to get vaccinated to protect themselves and the developing baby. Should my kids get vaccinated? This is my last one. So currently, like I said, children under 16 make up about 20% of the population. And currently, the EUA is only for 16 and up. The EUA for 12 to 15 is really expected in the next few days. Because the data in this group was excellent. I'll let Dr. Vinograd speak a little bit more to this. But the data in this group, actually, if you want to say 100%, the data in this group, in the treatment group, no, there were no cases of COVID. So that's really excellent. This was in the clinical trials, the smaller numbers that were initially reported. But that's a really excellent vaccine. So I'm actually really excited that it seems like the kids are going to respond quite well. Under 12, those trials are going on. We should have that data by this summer. All right, I'm going to leave you with one quick video, and then I'm going to turn it over to the panel. This is 1 minute long, so just bear with me. Oh no, there we go. Right. Oops, there we go. Great. Okay, so I am going to, I like that video. It always kind of gives me chills every time I see it. I'm going to stop sharing my screen, and I'm going to turn it over. So I want everyone to kind of give their professional and or personal stories about COVID, and then we're going to open it up to the audience and see what everyone else has to say. So Dr. Vinograd, do you want to take it over from where I left off? Because I'm sure you have a lot more to say than I do about.
Absolutely. Well, that was a real tear jerker of a video. Thank you. Thank you very much for handing it up to me just after that. So for the many of you who don't know me, I'm Dr. Vinograd. I'm a pediatrician here at York Hospital. And so I'm originally from Brooklyn, New York. I'm from a very small Russian part of Brooklyn, New York, called Manhattan Beach. It's right next to Brighton Beach. And my father is a Russian immigrant. He had a very famous, he had a very interesting saying that always stuck with me, and it's "Повторение мать учения," and what that roughly translated means is that repetition is the mother of all learning. And I think that's very relevant to what you're going to be hearing, not just from this panel, but from the social media, from news media. It's going to be a lot of the same messaging, and hopefully that messaging is to get your vaccines, and also the reasoning behind it. So, the one thing that I can give different than the other panelists here is that, so as a pediatrician, I only see kids 21 and under. And the American Academy of Pediatrics stats are showing that about 3.5 million cases of COVID-19 occurred in the pediatric population thus far, with about 300 life-threatening infections and even some fatal cases. Now, that number may seem very small compared to those astounding numbers that Dr. Thibodeau had just presented, and things that you're hearing on the media with very, very high mortality rates that we're seeing in adults. But the stats don't really matter when it's your child that's affected. So, it's really important to keep that in consideration. Having said that, I do have some skin in the game. I have two children, both in this community. My daughter named Evie is 5 years old, and my son named Alec is 19 months old. And soon enough, the vaccine is going to be available to their age groups, and it's going to be approved by the FDA. So far what we're hearing is that possibly by September that Pfizer and Mrna are their goal is to have it FDA approved by that time, by September. And so when it does get approved, one of the things that I've had conversations with my family about is, why would I vaccinate my children, given that there are all, having had two of the Moderna vaccine myself, and seeing, going through the nervousness, just as Dr. Thibodeau had mentioned, having some of the side effects, the soreness, the chills. I even had a low-grade fever. Going through all that, why would I want to vaccinate my children and potentially put them through something similar? Well, anytime I consider any treatment for my children, I always weigh the pros and cons. What's the benefit to them versus the drawback? Now, the idea is that the benefit would be to slow the spread of this virus. The more that we promote herd immunity, we're going to be able to keep our schools open. We'll be able to keep our kids in school, and anybody that has had the experience of remote learning and can compare it to in-school learning, really it's a completely different way of teaching, and it's a completely different way for children to grow up, including affecting their long-term developmental skills. So the other and the most important part of why I would vaccinate my kids would be to avoid the complications that can occur from acute infections. Now, we're very well informed about this condition called MIS-C, which is known as Multisystemic Inflammatory Syndrome in children. And it's a result of an acute infection, occurs about 4 to 6 weeks after the initial infection, and it presents with what is known as a Kawasaki-like syndrome. These are very sick appearing children, and it can be life-threatening. It leads to hospitalization, and it's a result of the acute infection. But it's not from the initial virus, it's an immune response that can occur. Now, this would be greatly reduced, number one, if we have our vaccines and we slow the spread of this virus, so we reduce the risk of our kids even contracting this virus at all. And then there's all these, there are a lot of symptoms that we're not even aware of yet. What used to be called the long haulers, and it can include central nervous system symptoms, and it can include pulmonary symptoms like shortness of breath. It can include systemic symptoms like fatigue, headache. It's a wide variation of symptoms that we're still trying to figure out as time goes on. One of the biggest things I want to emphasize, since the COVID vaccine really hasn't hit my population. 16 and up is currently going on, but soon enough it's going to reach, more and more of the pediatric population. And I just want to emphasize that vaccines are not a shield. They rely on your immune system to prepare your body for an acute infection. And the more that we vaccinate, we're hoping that acute infection may never even come your way or to any of your children. So I hope that my message is clear. I really advocate for vaccinations like anybody practicing evidence-based medicine should. And I'm always available for any questions, concerns here at York Hospital. And thank you very much for joining us. I'm going to hand off to Dr. Adams.
Thanks, Mike. Thank you, everyone, for joining today. Certainly, thank you, Evangeline, for the presentation. And I certainly want to, again, thank you and Gretchen Volpe, who we're very fortunate in our community to have two infectious disease experts that have really helped us navigate through this challenging time. I would say that unlike Dr. Vinograd, as a practicing internist, we take care of older individuals, and we've really seen this firsthand, the impact of individuals that are over the age of 65 or those with chronic medical conditions that have been impacted by this illness. And it's not an illness that not only increases your risk for death, but leaves some people with residual long-term symptoms. So those will be things that will be challenging for months ahead of them after their recovery. I think that I would encourage everyone also to get the vaccine. I think that as someone who received the vaccine, and I felt flu-like symptoms the second day, I actually had to stay home because I felt that poorly. As Dr. Thibodeau had mentioned, it typically lasts for about 12 to 36 hours, and then you're back to normal. All my family has gotten the vaccine as well. I think that one of the things that I've seen in the office here, as the vaccine has come out, those patients who have received the vaccine feel certainly much more confident on their ability to sort of deal with the day-to-day challenges of even going to the grocery store. They feel less apprehensive. They're certainly less anxious. I've tried to encourage them. Many of them have actually become even more engaged with regard to their care. For example, I had a patient the other day who I saw who used to refuse all his vaccines, including pneumonia vaccines. He was over the age of 65, but as soon as he got the COVID vaccine, he felt great. And so I took the opportunity yesterday. So that means I can offer you the other vaccines that you would normally be due for. So things like the pneumonia shots, as well as a shingles vaccine, which also impacts our community as well. And I think that the last point that I would leave you with, and we have been seeing this personally, that a lot of people have delayed their care, their preventative care over the last year because rightfully so of the concerns with regard to COVID and outbreaks and risks in the community. It's important to pick up again when you do for your colonoscopy. I had a patient recently that received her lung cancer screening CAT scan, in which we diagnosed an early lung cancer. So she had delayed her screening for about 6 months. So it's important to make sure that you get back and connect with your doctors and realizing that the science continues to evolve, but these vaccines appear quite safe. And we are very fortunate in the US here to be able to have access to them the way we did. Thank you.
Great. Dr. Kutz, do you want to speak up?
Sure. Thanks very much, Evangeline. I want to echo what Todd said. I think we're really fortunate to have you and Gretchen as resources in our community, and you've done so much for us over the past year, so thank you. I wanted to give just a very brief update of what's being seen across the state from a hospitalization standpoint. The medical leadership of the hospitals across the state of Maine get together once a week to sort of just check in with each other. And what we're seeing right now is that the folks getting admitted to the hospital with COVID are tending to be younger, and they're tending to be sicker. And so if we thought that this was a disease that primarily impacted older adults, in fact, that's not what we're seeing at the moment. Locally, when the vaccine first became available, there was a tremendous demand. All kinds of people were coming out of the woodwork wanting to get vaccinated as soon as possible. And what I would tell you is that right now we've actually worked our way completely through our waiting list, and we have capacity in our vaccine clinics. So now is a perfect time to come out and get your vaccine. If you haven't done it already, it's easy. The process takes probably a total of 25 minutes in the vaccine clinic, most of which you're just being observed. So we've really tried to make it as easy as possible for people. As far as the question about, why did I get vaccinated and why do I recommend it to everyone else? I would say a couple of things. This past year has been a really hard year for a variety of reasons. Being stuck at home, unable to do the things that you would normally do has had a major impact on people's mental health. And getting vaccinated is a step that you can take to actually start to take your life back and get back on track. When I think about, the what ifs, well, what if the vaccine does something to me down the road and I don't know about it? What if? I think you can get paralyzed with those what ifs. And the bottom line is that life is short. We want to get back to doing the things that we like to do. And really, there is risk everywhere. There's way more risk getting in your car every day than taking this vaccine. And the last thing that I would share is that my daughter is 12, and as soon as we have vaccine available, she will be in line to get it. Thank you.
Thanks. Dr. Volpe, do you want to speak? My partner in crime.
Hi. Well, I think basically everything I had thought of has been touched on, and certainly actually the video you showed really was kind of what I was thinking about, is just, even if you never get COVID and you're not really worried about getting COVID, your life has certainly been affected either because of education, the economy, your workplace, mental health, anxiety, depression, certainly in the elderly, isolation from family members has been a big deal. And for some people, even food security has been affected. So, and obviously the healthcare system, we've been in healthcare, so we can see firsthand the impact on the healthcare system. So really no aspect of life has been left unchanged. So even if you never have COVID, your being vaccinated is important for all those systems to go back to the way they were before. So pretty much what everyone has said, but vaccination for everybody is a really important part of that.
Great. We have a few questions in the chat. Thank you, everyone. And I will, okay, the first one is with the J&J, were women on birth control at a higher risk? I don't think we have that data. I personally don't know that data. I don't know if any of the panelists know that. We do know that birth control is a higher risk of thrombotic events in this vaccine potentially as well. So unfortunately, I don't have that data. If we see that, I can certainly get back to our folks to answer that for you. The next one is, how reliable are these home testing kits? And if positive, is the result reported to the state? Home testing kits, from my understanding, they're a bit less sensitive, and I think it's up to the individual to report it or to go and get a confirmatory test. Does anyone else have a good, any other clarification on that?
I do not, Evangeline. I will say that just as vaccine has become more widely available, testing has become much more widely available. So it certainly has been easier to, although times may have shifted, it has been easier for us to arrange for testing than it has been in the past. And we've certainly over the 15 months here have seen certainly that turnaround time improve as well.
Great.
The only thing I would just add to that is, I think that there's definitely going to be a time and a place for home testing kits. I know that the pharmacies are starting to sell rapid antigen testing kits that parents could just go to the pharmacy and buy. The one caution is that I would just suggest, if there are any symptoms that you're concerned about, it's important to actually be evaluated. We could always do we can start selling rapid strep tests to be sent home for parents to do at home as well. But it's not, we're looking for, more than just that one isolated virus or just that one bacterial, throat infection. We're looking for, pneumonias, ear infections, complications from any of those conditions as well. So I would just encourage, again, from a pediatric perspective, I would encourage parents to bring kids in if they were concerned and wanted their testing to be completed, including rapid antigen testing. We have that available at York Hospital.
Great. I'll give this one to Dr. Volpe. Are we still concerned with transmission via surfaces?
So initially, there was more concern about what we call fomite transmission, which is inanimate objects. That is been evaluated and felt to be pretty low risk for transmission. But I would say, remembering that it's probably not zero, and also that your hands are a little bit different than inanimate objects. So hand washing is, especially because when you touch inanimate objects with your hands and they go directly to your face, that's a different story than having, an inanimate object that's not been touched for a while. So hand washing is still considered a cornerstone of infection prevention for COVID, but also for many other infections. So I would say, inanimate objects are probably, or surfaces are probably low likelihood of transmission. However, your hands are a good transmitter of infections, and you should always practice hand washing. Great.
Booster shots. So do we need to get a third boost? So assuming, the mRNA vaccines are 2 shots. So do we need booster shots? We usually get flu vaccine once a year. What about COVID vaccine? So right now it looks like the mRNA vaccines do have a good, there was detection of neutralizing antibodies for at least 6 months. I think that the data is still going on. How long? These trials started last year, so they're still following all these patients or these participants. So it's likely that we'll need a booster shot, something like the influenza vaccine that we're going to get once a year. But I think our focus right now is just getting everyone their first vaccine. So, and getting the level of virus down now. But it's likely. Anyone else have thoughts on that? Okay. Oh, we've got a few more popping in. Great. Okay, you guys already touched on it. Do you have a sentence I can say in response to people close to me against the vaccine? Okay, so they don't trust the government and think there may be long-term side effects. So I spoke on the long-term side effects a little bit. And like I said, there's no absolutes. There's no, but the safety data did go out for at least 2 months. As I said, typically in vaccine trials, if you're going to see a side effect, you're going to see something severe, you're going to see it within the first 2 months. Look at these mRNA vaccines that have been in practice now for over 5 months in the population, and we haven't seen that much. That's pretty good. Again, like I said, there certainly could be things that pop up later. And, we've seen something with the J&J at this point that wasn't detected in the clinical trial. And that's why there was an appropriate pause to really vet it out and look to see if this is what kind of concern, what level of concern this should be. So I think that we need to trust the career scientists on this one and really know that they're going through all their safety processes. I don't know what to say about trusting the government. That's a tough one. That's a really tough one. I think you got to get, I don't know, anyone else have something to say on that?
I mean, the only thing that I would add is that, I had a patient today who was prescribed cholesterol medication 2 months ago and then didn't start it because he was concerned about all the side effects that he had seen online. So after talking through some of the information, giving is, if you have that relationship with your patients, to be able to give them your heartfelt recommendation that we do think that this is safe, that, if it was my parents or my relative, that I would certainly, I always hate when they ask me that question, what would you do? But I would certainly give that recommendation that I would be vaccinated, and in this instance, obviously take his cholesterol medication. But I think that there's, as Dr. Cutts mentioned, there's risks in everything we do. There's risks in every approach that when you choose what type of food you want to eat, or whether you ride a bike or in a car. I think there's always some inherent risk, and we don't know everything 100%, but based on the information we have, this is the best recommendation we can give you.
The other thing I've heard go ahead.
Oh, also, you're comparing it to the risk of COVID infection, which we do know the risk of COVID infection. So,
yeah.
The other thing I've heard mentioned, and this is not exactly my idea, but I've heard others speak to this, is when, you disagree with someone on something is as opposed to, butting heads, is really getting to the whys and trying to kind of understand what the concerns are and maybe getting at that a little bit instead of, that's why we're here for you now, is to answer your questions, because we want to help you navigate and help you. A lot of people here are probably not sure if they have concerns. This is the platform to do it. So if you have a personal situation, I think maybe getting at asking open-ended questions and really getting at the why and trying to help them navigate that. Okay, anyone else speak to that piece? We have another question coming in. I just heard someone mention York Hospital does do rapid testing. Yes. So we have the rapid antigen testing at our walk-ins. And it's just, is that, someone else can speak to this, probably Dr. Vinograd or Dr. Cutts. I think, is it just Monday through Friday, or is it the antigen testing? I'll let you guys take that one. If I need this test prior to international travel, the hospital can accommodate. International travel, I think they require PCR tests. We do not have rapid PCR tests in the outpatient setting, but maybe Dr. Cutts can elaborate on that.
I could speak to the rapid antigen testing. It's at the York Walk-in Clinic. The York Walk-in Clinic, correct me if I'm wrong, but it's Monday through Sunday, and it's 8 a.m. until 6 p.m. I believe is when they close. I know because sometimes I'm still there doing my charting. so it's available at the York Walk-in Clinic from Monday through Sunday from 8 a.m. until close.
Just to confirm, it is available on the weekends, and it's really only meant for folks who are symptomatic, so it would not be a good test to do if you were getting ready to travel.
And we're looking at the updated travel guidance, but I would suggest if you are traveling internationally that you very closely look at the requirements for the place that you're going to, as the requirements vary for the type of test, PCR versus rapid versus antigen. And sometimes they're very specific about which tests, and also whether or not you've been vaccinated may also play a role, and different forms of proof are required by different countries. So certainly pay very close attention to what type of test, the timing of the test, and how you provide evidence of having had that test before you travel.
Great. So I want to give 5 more minutes to questions. If anyone wants to pop a question in the Q&A, just to make sure we are here for you. Okay, that was just in the chat. Great. But that's not a question, sorry. So awesome. Anyone have any closing statements or thoughts they want to say before we close out? And is there anything else you feel like we haven't touched on, or any last burning questions? Why is herd immunity so elusive? Elusive, I mean, so herd immunity is based on calculations and models. So it is, it's an estimate. And it's different it's based on that R naught. On my slide, 4th or 5th slide, it's based on the number of people one person goes on to infect. And that changes on an individual basis, as well as between different pathogens, as well as within the same pathogen, like SARS-CoV-2 has different variants that are more transmissible than others. So that's why herd immunity, and right now some people are saying is up to 90%. If we have new variants, we could even raise our threshold up to 95% or so. So that's why it's tough to figure out, and I'm glad it's not my job. Are we able to request which vaccine we want? I've heard that the Pfizer is recommended for breastfeeding pregnant moms. So at this point, Jenny, do you want to speak to that? I don't know if we allow that at York, and I'll let you speak to that one.
At this point, we have just the Mrna vaccine in our vaccine clinic. I haven't heard specific information that one is preferable to another in any particular patient populations, with the exception of the Pfizer being the only one that's currently approved for 16 and 17-year-olds. So at this point, we don't have the ability to do that, but things could change in the future. We don't know.
Then the last question here is about herd immunity, that we may not be able to achieve it, and we may not. I think what we're gonna, like I mentioned before, we're probably gonna live with COVID for a long time, and that we're gonna have pockets of increased rates in certain geographic areas, as well as seasonality. But we want to get it down to a level where it's not impacting our lives so much like it has over the past 14, 15 months. The best way through that is with vaccination. Great. I don't see any other questions popping in. So thank you all for coming. If any other questions come up, feel free to email the community relations email, and we will we'll get back to you.
Thank you.
Thank you.
Thank you.
Thank you very much.